Okay, Chapter 30. Chapter 30 is musculoskeletal trauma. Musculoskeletal trauma is another area of medicine that tends to get a lot of attention because they tend to have some pretty dramatic looks to them. So musculoskeletal trauma, however, in many cases is not particularly life-threatening. So we have a number of objectives, of course, you'll find on 695 in your textbook. Kind of a little bit longer chapter, but a lot of it is hands-on. So this one is kind of a fun chapter when it comes to skills time. There's a lot of different equipment, a lot of different skills that we get to use and try out. A couple multimedia videos. One about hip fractures, which is a very, very regular call for us to go on for the fact that many of our older population end up with a hip fracture at one time or another. And then as well as a immobilizing a long bone video. Alright, so understanding bones, our core concepts, understanding bones, muscles, and other elements of the musculoskeletal system. Then understanding the general guidelines for emergency medical care for musculoskeletal injuries. Look at the purposes and general procedures for splinting. And the assessment and care of specific injuries to the upper and lower extremities. So it's a quick reminder, the musculoskeletal system is composed of the bones, the joints, the muscles, cartilage, ligaments, and tendons. All of those are components to really our locomotive system that allows us to get up and move around. Bones are the framework, joints allow us movement and bending because they are a junction between bones and muscles. Remember, when the bones and the muscles work together or against each other, depending on the situation, this is when we get movement at those joints. So that's the flexible point within a rigid structure. The cartilage is usually what lines those joints and therefore gives some flexibility. And then the ligaments and the tendons are the ones that do most of the joining between the different structures. Ligaments, remember, ligaments are alike, so Li and ligament and like, so the like structures, bone to bone. Tendons connect muscle to bone. So if you want a good example of a tendon, think of your Achilles tendon. That's the one that comes off of the back of your calf and attaches down to the bottom of your heel. So the bones, remember, are formed of dense connective tissue. They're very vascular in most cases, the long bones particularly, and then the larger bones. They can be susceptible to bleeding if they become injured. Now, with the exception of, say, the femurs and the pelvis, and to some extent the humerus, there's not a giant risk of severe hemorrhage in most cases. But remember that the bone marrow cavity, particularly in the bigger bones, is where there's a lot of storage and production of blood and blood products. So we have a number of shapes to bones. The long bone is probably what most people think about when we talk about bones. The long bones being generally the bones of the arms and the legs. They're long, usually have a head on each end of them, and then a more slender shaft. We have irregular bones. Irregular bones are bones that don't really fall into the other shapes. So the vertebrae are a good example of the irregular bones. We have short bones, such as those of the fingers and the toes. And then we also have flat bones, such as the ribs. So bones do a generally good job of healing and self-repair. However, that does take a significant amount of time. Anybody who's broken something in the past probably can speak for that. Breaks will cause that soft tissue swelling and a blood clot in that fracture area. The interruption of the blood supply causes a certain section of bone to die, and then the cells further from the fracture divide rapidly, forming tissue to help heal a fracture and develop into a new bone. So basically it's the neighbors that help rebuild all of that missing or dead bone tissue there. So to compare the muscles and the cartilage and the ligaments and the tendons, remember we have three major types of muscles that we deal with on a in the human body. You have striated muscle, and striated muscle is also called skeletal muscle. The skeletal muscle is what we generally have voluntary control over. So the things that make us get up, walk around, pick up a cup of coffee, or what have you, are generally skeletal muscle. Things that are more involuntary would include the cardiac muscle and the smooth muscle. So cardiac muscle is specific only to the heart. It's special because it creates its own stimulus, as opposed to skeletal and smooth muscle requiring external stimulus. That's not to say that the brain doesn't have influence on the heart, but the heart does have its own ability with something called automaticity. Smooth muscles, on the other hand, smooth muscles are the muscles that are typically found in all of our tubular structures of our body. So, for example, our esophagus, intestines, our bronchi, in our lungs. So any of those things that are tubular in nature generally are composed of smooth muscle, and again are fairly involuntary. When we look at examples that we have shown here, we have the really it's the knee joint that they're showing here, and they're showing it from a couple of different angles, and they evidently are showing it. The one on the left would be from the posterior or from behind. The one on the right is from the front, showing us that the patella is being represented on the one on the right. So that would be your kneecap. We have examples where tendons attach a muscle into a specific bony part or portion, and the ligaments themselves tie the bones together. So when you hear this time of year during football season, you hear about people getting tears in their ACL or their anterior cruciate ligament, and those are ligaments that kind of cross over in the middle of the joint of the knee there. So some general guidelines for emergency care. Well, we have a number of mechanisms that create musculoskeletal injury. In many cases it is a direct force, but occasionally we also will have some indirect force, and then twisting or rotational force. So they show you the direct force here. The guy slamming forward, doesn't have a seatbelt on, slams forward into the steering wheel, steering column, and that's when you get the injury directly to that bone. Indirect force, on the other hand, may include forces that are passed along. A good example of an indirect force injury actually would be somebody who jumps and falls and then lands on their feet. The force goes up through their legs, up through their pelvis, and into their back, and then they would say fracture a vertebrae. That's fairly common. And then severe twisting or rotational force. In this case, they show you the guy kind of getting hung up underneath the pedals down in the floorboard, causing his ankles to twist. And most of our joints don't deal well with twisting unless we're talking specifically about the head and neck joints. That is intended to twist, but only to a certain degree. So when we talk about bones and connective tissue injuries, we have a number of types of injuries that we deal with. In the end, when they're at the hospital, yes, they are going to be treated somewhat differently, but even then, a lot of them are treated fairly similarly, especially if they're a simple injury. In the field, we almost always treat them just about the same. So treatment for these is pretty simple. We don't have a lot of sorting one way or another. So when we talk about fractures, fractures are any break in a bone. So a lot of people think that there's a difference between having a fractured bone and a broken bone, and there really is not. A fracture is any break in the bone, and this can be either open or closed. Open or closed, these are terms that we formerly used compound and simple. So if you've been around a while and you've heard a compound fracture, that is what we now call an open fracture. And a closed fracture is a simple fracture. So the closed fracture is just a break that does not break the skin. There are numerous types of fractures. There's only just a handful listed here, not even a handful. We have the comminuted fracture, where it is broken in several places. So you might have chunks and pieces in there. When you hear people say, oh, it was shattered, they probably meant comminuted. Green stick, this is an incomplete break, so it didn't break all the way through. This tends to be a little bit more common in kids, simply for the fact that they have not ossified well, and therefore they have more pliable bones. And then angulation. When you get an angulated fracture, it is when it is bent to a certain degree. The next type of injury to discuss would be then dislocations. And dislocations are when things come apart in a joint. And in most cases, when we say dislocation, people really think that it's severely offset and majorly out of place. And that's probably the classic thought. But in reality, more times than not, when we deal with dislocations, we're probably actually dealing with one that's really not far out of joint. Maybe it had enough stress on it that it did pop it out, and then it popped back in. And then we have sprains and strains. Sprains occur by stretching and tearing ligaments, so that is generally in a joint, and a strain is generally away from a joint. It's in the longer stretches because it is a overstretching of muscles, and these are typically longer muscles, larger muscles that tend to be involved. So not all injuries can be confirmed as a fracture in the field. I think if we take a look at the picture on the left there, it's probably going to be fairly evident in the field that that person has a break. They have some sort of a fracture. Whereas if we look at the picture on the right, there is a fracture there. You can see the fracture in the bone if you look at the x-ray. Just a little over halfway down the shaft of the what appears to be the tibia. Tibia is the bigger one, and the fibula the smaller one there. So just a little over halfway down the shaft of the tibia there, you have a crack in that bone. So now that one may not be very easy to diagnose in the field, if at all. So splinting an extremity with a suspected fracture is going to help us reduce pain, most of all, blood loss, additional swelling, and additional injury, because if we leave it unsplinted, it allows it to just kind of move freely. And in the case of the picture on the left, that moves around a lot. It's pretty obvious that that's going to cause some damage to the surrounding tissue. Granted, it's going to be muscle tissue, but muscle tissue has to heal just like bones does, or do. Another advantage to splinting, say the picture on the right, is we can hopefully keep from making that green stick fracture there a complete fracture. So we can reduce that. Hopefully their healing process is going to go along much quicker. So assessing musculoskeletal injuries, we've got to rapidly identify and treat the life-threatening conditions. we don't always have people that have life-threatening conditions. In fact, in most cases, we don't. I brought this up before in the class, and life threats are few and far between, really, in our field. So don't get distracted, though, by the nature of some of these injuries. My very first call in EMS nearly a quarter century ago was a lady who had fallen down and fractured her forearm, and is something that is sometimes referred to as a silver fork fracture, where it had the curve. If you would take a fork and lay it tines down, not the standard way we usually have it, sitting on a table, but turned over, it had that kind of curve that you would see in her forearm. So there's this big kind of S-shaped curve in her forearm. Obviously, it's not supposed to be there. Well, to somebody who's on their very first call in EMS and bright-eyed and bushy-tailed and doesn't know a single thing about medicine, really, that was pretty awesome, and what I thought was probably pretty serious. And in fact, it was pretty simple. But so we got to not be distracted by some of those things that might draw our eye initially, and make sure that we check for the life threats before we move on to playing around with broken arms. Be alert for injuries besides the grotesque wound. This backs up what I just said as well. They may have called you, and because they fell down and they have this big fracture on their forearm, but maybe they didn't realize in the process that they also lacerated the back of their scalp. They've been kind of distracted by this awesome looking wound, and the hemorrhaging may have just been overlooked. So don't forget to look for those things. Pain and tenderness. Obviously, that's huge. Most of the time, there's pain with a fracture. Tenderness often goes along with that. Remember, pain is usually a constant thing without provocation. Tenderness usually is something that you'll get upon palpation or movement. So deformity and angulation. Again, not all fractures have deformity. Not all fractures have angulation. So we also may have crepitus. Now, there are two types of crepitus. There's bony crepitus and there's airy crepitus. In patients with some chest injuries or neck injuries, you occasionally will run into something called subcutaneous emphysema, which it feels like some little bubble wrap underneath their skin. That's called airy crepitus. But bony crepitus is the grating of bone ends on each other as the bone moves around. Hence the reason why we want to splint that. Swelling. Obviously, the longer you go from out from the injury to an extent, usually within 48 to 72 hours, the swelling starts to subside, but you get some significant swelling. Bruising. Bruising is not always evident for us in the immediate acute setting, but over time, bruising will start to settle in. You, of course, may have exposed bone ends in an open fracture. You may just have an open wound and no exposed bone ends. Occasionally, we also have people who break a bone. The bone comes up through the skin, punctures the skin, and then in the process of them moving or decelerating or whatever, then the bone naturally retracts back in without us doing anything to it. So if you have a fracture and in the immediate vicinity there is a significant laceration, you may also be dealing with not a fracture and a laceration, but a laceration that is a result of the fracture. Nerve and blood vessel compromise, decreased CSM. So when we talked about patient assessment all those moons ago, we talked about checking the CSM or the PMS or whatever way you want to do it. But we're checking the circulation, the motor function, and the sensation of the extremities. And the reason we do that is if we have a significant injury, we can occlude some of those vessels, or we can pinch off nerves. So we'll say, for example, a significant dislocation, which tends, more times than not, tends to be in the dislocations where we see these, that neurovascular bundle, which is usually an artery, a vein, and a nerve that kind of run all together down the shaft of a bone, can get pinched because things came apart, things moved around, and then maybe a loop of that neurovascular bundle got in between the two bones when it settled back together. And then occasionally we also have something called compartment syndrome that happens. And compartment syndrome happens when something is so tight, and when we talk about it as a compartment syndrome, it's usually swelling from the injury has created so much swelling and pressure that the skin doesn't give, or the fascia is actually what the problem is, which is the tissue that surrounds muscles, doesn't give, and the pressure starts to swell inward, and as it swells inward, it starts destroying tissues. So that's where compartment syndrome comes from. Occasionally this happens when a cast or some sort of an immobilization device gets put on too tightly, but compartment syndrome is inward pressure on all those structures. So there's really 6 P's to the assessment of a musculoskeletal injury. And those 6 P's include pain or tenderness, pallor, which is pale skin, paresthesia, pulses, which are diminished or absent. Paresthesia is pins and needles, that kind of your arm's asleep, your foot's asleep. Paralysis, can't use it, and pressure. They feel a pressure or a tightness. All right, so do my patient's musculoskeletal injuries add up to a serious multiple trauma? Occasionally they do. In most cases when we're dealing with the musculoskeletal injury, it's fairly isolated. You know, somebody fell down and tripped and broke their arm, or somebody sliding into base and broke something, or what have you. But there are certainly occasions in which we may have a broken arm and a couple broken legs, and maybe it's, a fracture somewhere in the rib cage. That adds up quickly. Does my patient have circulation sensation and motor function distal to the suspected fracture or dislocation? That's huge, because it's something we can potentially do something about in the field a couple ways. Number one, by not sticking around on scene messing around for too long. But 2, in some cases, we are allowed to reposition and try to get some of that CSM back. So before we go on to this next slide, if you'll take a look at page 706 and 707 in your textbook, it shows a couple of different types of fractures that we're dealing with, where we're talking about open fracture versus a closed fracture. The open fracture on 706A, that's really the end of the tibia and probably fibula poking out there as the foot is angled off to the side. And then B, it's really the same area of the body, the lower leg and the foot, with a serious, it's probably a closed fracture as well, but it's definitely dislocated on top of it. And then they show a couple of good examples there on 707 with the fracture of the forearm in A and B there. And then they show a good example of how the patient's right shoulder has been dislocated in the picture there. All right, so treatment for musculoskeletal injuries. Take standard precautions. It may not be bloody at the moment, but all it takes is a little bit of a slip, something pokes through, and now you've got a bleeding patient on your hands. Perform your primary assessment and assess for life threats first. Even though these things are grabbing our attention, they're not life-threatening in most cases. Take spinal precautions if necessary. You have to look at the overall mechanism. If I was walking along, tripped on the sidewalk, reached my hands out in front of me, caught myself, and now I have a fractured forearm, chances are probably pretty good that my head, neck, and back are okay. If I fell off of a 2-story building and I've got some pretty radical fractures in my lower legs, chances are that some of that energy was also transferred up through my spine. So spinal precautions would be appropriate in those cases. We're going to splint any suspected fractures after treating the life-threatening conditions. And actually we're going to splint any suspected fractures, dislocations, and potentially be splinting some sprains. Usually we don't need to splint a strain. So splinting any suspected fractures after treating life threats and assuming C-spinal immobilization. Don't forget to cover open wounds with a sterile dressing. We still want to work to keep the outside dirty world from getting inside our patient's body. So we cover it up with a dressing when possible, control bleeding as necessary. So the advantages of splinting: it minimizes the movement of disrupted joints and broken bone ends, which is nice because it goes on to prevent additional injury to all the surrounding structures. It decreases the pain. It can minimize blood loss. Remember we talked in the bleeding wounds and shock chapter that sometimes we have more movement in an area. More movement in an area dispatches more blood to an area, therefore they're going to continue to bleed. And then it can prevent a closed fracture from becoming an open fracture. If you end up with an open fracture, the chances of you getting an infection within your bone is huge. You have a very good chance of getting what's called osteomyelitis, or a fracture within the bone, which requires months and months of antibiotic therapy in many cases in order to get over. And we're not talking just taking a pop and a pill every day. We're talking usually IV antibiotics. So there are some general principles of splinting. Care for the life-threatening problems first. You can use the whole body splint. Remember, the whole body splint is the backboard or the long spine board. Expose the injury site. You cannot appropriately assess it and treat it if you can't see it. Before doing anything else, assess the distal CSM. You want to make sure that it is present. Align the long bone injuries into the anatomic position. If you can, move it back into a fairly normal position, do so. If you meet resistance or incredible amounts of pain, then immobilize it in the position found. But if you can put it back into a normal position without it becoming ridiculously painful, do so. Do not push protruding bones back in. So if you have an open fracture, we do not intentionally try to put it back in place. However, if when we are realigning it, they just so happen to go back in, so be it. We're going to immobilize the injury site and the adjacent joints. And when we say that, so let's say that you fractured your radius in your ulna, so your forearm. We're going to immobilize those bones and the joint on each end. So the joint above and the joint below. So we would also immobilize the wrist and we would immobilize the elbow. The reason for this is you have those tendons, you have those muscles and ligaments that are attached in there, and mostly we're talking muscles and ligaments, but as things are moving, it's moving the bone. Maybe it's ever so slightly, but if we still can move those joints, the bone is moving somewhat. So that's why we immobilize the sites above and below. This rule also applies when we're immobilizing a joint. So let's say we have a dislocated elbow. We're going to immobilize the elbow, and we're going to immobilize the bones below, the radius and ulna, and the bone above, which is the humerus, for the very same reason. We're going to choose a splinting method based on the severity of the condition, the priority decision, and what we have. There's lots and lots and lots of different potential splints out there. Not every service carries every type. So apply the splint before moving the patient to the stretcher when you can. If you have a life-threatening condition, remember we long boarded them, we used that as a whole body splint, and then we'll get them going on the way to the hospital. And then if we have the hands, we have the time, we may go back and then do a better job of splinting whatever fracture or injury we found. And then don't forget to pad the voids. Anywhere that we're putting an immobilization device on a person, backboards included, we need to pad the voids. And what padding the voids is, remember, is we put something in the spaces. So if you will take your arm right now and lay it on something that's perfectly flat, a table, desk, whatever. You put your arm palm down flat on this desk, table, or what have you. You probably have some space underneath your wrist because the palm, the base of the palm of the hand tends to be a little fleshier, and then of course the upper parts of the forearm are fleshier, so you probably have an itty-bitty amount of space beneath your wrist, and that would be a void. It would be something we want to pad. So we maybe would take some dressings or some bandages and pad in that area there. Some of our splints take care of that for us. Say, for example, a SAM splint, which is often called a moldable splint, or an air splint or vacuum splint. Any of those generally do a pretty good job of kind of naturally padding voids for us. Realigning a deformed extremity. So this assists in restoring effective circulation to the extremity and to fit it into a splint. If it is not realigned, the splint can be ineffective. It can cause increased pain and possible further injury. However, again, sometimes we run into those cases in which it will not realign without becoming ridiculously painful, and in those cases we have to splint in the position found, or if it's locked into place. If it's not realigned, we increase the chance of the nerves, arteries, and veins being compromised just because it's out of its normal position, things are moved. The increased pain is generally only momentary. However, sometimes, like I said, it just is too much. So we do have some hazards of splinting. One of those being splinting the patient to death. Well, when we spend more time playing around with our different splints than getting the patient's life threats taken care of, their ABCs and their transport to the hospital, we can actually basically kill them in the field because we were concentrating on the areas that were not really that important. Not ensuring ABCs. We can splint too tight or too loose. If we splint it too tight, it compresses the tissues, and these tissues start to swell, and again, we can get sort of a compartment syndrome going on in which there's inward pressure on everything, and it starts to destroy tissue. The splint can be too loose. If it's too loose, this allows for too much movement, and essentially we could have just not splinted at all because it did no good. And then splinting in a deformed position. This is, again, kind of a judgment call. It's if we can get it moved to a normal position, do. If you can't because it's locked into place, you got to splint it where it's found. All right, so the treatment: splinting long bones and joints. Select the appropriate splint for the injury, standard precautions, and then manually stabilize. This is when having partners or bystanders is huge. Somebody comes and they hold on, just like the gal in the picture is. She's holding on to manually stabilize the injury site. A lot of times the patient also does this, particularly if it's an arm. They hold it up close and tight to them. Assess the CSM in that area, so pulses, capillary refill, sensation, whatnot. Realign the injury if it's deformed or if the distal extremity is cyanotic or pulseless. That's the case in which we really want to talk about moving it to a normal function position, because if we have CSM that's impinged, then we can really potentially have the patient who loses an extremity. So measure or adjust a splint and then move it into position. apply it and secure the splint to immobilize the injury site and the adjacent joints, and then reassess the CSM distal to the injury. Now that all sounds very easy, but in reality, we have to know how our various splints work. Those are the general guidelines that we use when immobilizing bones. Different splints have different requirements for what we have to do. In this example they're showing is the traction splint. And this is what is referred to as the bipolar traction splint. If you look in the bottom left box, you can see the splint itself right there. But the bipolar is often called the Hare traction splint. Hare was one of the first companies that made it. But so with the traction splint that they're using, can only be used on a mid to upper shaft femur fracture. You can't use it on any other bone. So mid to upper shaft femur fracture. And you can see that they've started to assess the patient. She's holding some manual stabilization. I encourage you to use the terminology manual stabilization. What I don't care about the way she's doing this here is she is holding the lower leg and kind of allowing the upper leg where it's fractured to bow. So she's not supporting the upper leg like she should be. In the bottom left picture there, he's mobilizing, or he's measuring the splint against the good extremity because he needs to extend it about 10 inches beyond the foot of the uninjured extremity. And then they're securing the splint to the patient, and we'll apply traction and so on and so forth. Now, we will have much more in-depth discussion about how to do splinting in the various skill sessions. That will take up a significant amount of time during skill sessions to try out all the different types of splints that there are. Alright, so some specific shoulder girdle injuries. Assessment of a shoulder injury, shoulder girdle injury, a dislocation in this case. There's pain. The shoulder may be dropped, or it may be very oddly deformed, such as this one where it's pushed up and out. It may occur from a severe blow to the back over the scapula. Treatment is generally going to be obviously assessing the distal CSM before and after we do any splinting, and use a sling or a swath, and do not attempt to straighten or reduce this unless you have the CSM that's impinged or hampered. Then you may want to try to move it a bit, try to restore some of that. Wrist and hand injuries, signs. The forearm generally will have deformity and tenderness. Wrist will have deformity and tenderness. The hand typically will have deformity and pain and could potentially have dislocation of its fingers. We generally are going to use a padded rigid splint from the elbows past the fingertips. And we can put a roll of bandage in the hand. By doing that, we are putting the hand in what's called the position of function. So that's the least stressful position for that to be in. Now, when we say a padded rigid splint, what does that mean? If you would look at a good example on 714, they're using a padded rigid splint, basically a board with some padding around it. Is how easily you can make it. Another good example of a commercial padded rigid splint, if you look on 711, there is a couple of orange splints to the right side of that blue backboard. Those are padded rigid splints. So those are a piece of wood with some foam on one side and then wrapped in plastic. So that padded rigid splint from the elbow past the fingertips, roll a bandage in their hand, and then sling and swath because we need to immobilize the elbow joint. We could also do a soft splint. We could do a roll of, or bandage in their hand, tie their forearm, wrist, and hand into one of the pillows or between two pillows. And then if you're going to do like a finger, you will just buddy tape it to an uninjured finger nearby. So when we say, how are we going to do this padded or the soft splint with the pillows and whatnot, this is basically, you take a pillow and you kind of taco shell it up around a person's hand, forearm, or whatnot. That also works very well for ankle injuries as well. Pelvic injuries, there'll be pain in the pelvis, the hips, or the groin, pain when pressure is applied. We're not pushing a lot of pressure on their pelvis once we are doing our assessment. It's just enough to see if there is any complaint of pain. Cannot lift their legs. They may have lateral rotation of the foot, so their foot may be rotated outward instead of more towards the front or up in the case that they're lying down. They may also have some unexplained pressure in their bladder. The treatments for pelvic injuries, moving the patient as little as possible. This is one of the areas that has so much blood supply to it that you can develop a life-threatening hemorrhage from this fracture. Determine CSM distal to the injury, of course. Straighten the lower limbs into an anatomic position if possible. Stabilize those lower limbs. Assume spinal injuries, and then treat for shock. So you can see they have this person immobilized to a backboard. They basically have taken and placed a blanket between this person's legs and then essentially buddy tied or buddy taped the legs together just to reduce the amount of movement. There's another thing that some places are doing. It doesn't have 100% buy-in by the medical community, but it's the pelvic wrap. And the pelvic wrap, you can see an example of this on 720 in your text, where they basically are taking a big long sheet, wrapping it around, and then crossing it over and then tying it off. And the problem with this is it's not shown to be a very advantageous, and there's little research to support it. Another potential splint for the pelvis would be MASP pants or PASG, but you would usually use those with extensive lower extremity trauma as well. Hip dislocations or fractures, anterior hip dislocation or posterior, they can go either way, where it pops to the front or it slides out to the back. If it's posterior, typically you'll have rotation of the leg and foot, and it's more times than not rotated inward, whereas an anterior tibia dislocation, it may rotate outward a bit. When you have hip fractures or dislocations, you usually also will have some shortening, so one leg will be shorter than the other. They obviously will have lots of pain and will be unable to stand. Here they're going to show the pelvic wrap here, which is not actually that appropriate for a hip dislocation or fracture. But in some places, again, they have picked up on this and they're using it. There are also some specific pelvic binding splints that you can put on patients as well. They were actually, there's a lot of research done on them for in-hospital use and hardly any done on pre-hospital use, and there was a good smart marketing department at a company that started really pushing these in the field, and then come to find out they didn't work so well in the field. But so assessing CSM, spine board is the best splint for these people. Immobilize, usually padding between the legs, buddy tie the legs together, secure them to the backboard, and then of course reassessing their CSM. Sometimes we even put a long rigid splint between the legs. Femoral shaft fractures, so mid to upper shaft femur fractures, they will have intense pain. It's very possible that it will be an open fracture, and they will generally have a significantly shortened limb, the one that's fractured, of course. This is the longest and strongest and heaviest bone in the body that has been broken and is now being pulled on by the thickest, heaviest muscle mass in the body. Treatment for this is going to be to control bleeding. This is another area in which you can have a life-threatening hemorrhage. So messing around on this is not recommended. Checking and rechecking CSM. Traction splint is usually the splint of choice for these. The traction splint is basically got a little winch on the end of it that starts pulling on that leg, and it pulls the leg back out to its normal length. It does initially hurt a bit to do this, but usually the patients, after you get it applied and applied correctly, have extreme amounts of relief. It's not going to completely remove all the pain, but it greatly reduces their pain. And then treat this patient for shock as well. Knee injuries. Patients with knee injuries. Usually pain, swelling, tenderness, deformity with some swelling as well. Generally immobilizing in the current position, particularly if we've got dislocations, but sometimes that can be difficult to do as well. If we've got it, the person's got it in a bent position, we have to be creative in how are we going to immobilize this. So maybe putting some rigid splints at an angle, make sure that we're padding with some pillows and blankets under the knee to allow it to be supported when it's up in the air. Tib-fib injuries, typically either an air-inflated splint. We can use a two-splint sandwich method where we'll put two board splints on either side of the leg and then secure those together. There's a different type of splint that kind of has a little ankle hitch to it. It's similar to a traction splint, but it isn't officially one. Ankle and foot treatment. Here we go. Here's a good example of a pillow splint or a soft splint where they just taco shelled a pillow up around the foot there. Another good way that this could have been done is they could have actually turned the pillow the other way, and then instead of sandwiching it from the back side of the leg, sandwiched it up from the bottom side of the foot and taco shelled it up around there and tied it into place. So a lot of times it's stabilization, lifting up the limb, cravats, tying the pillow. Air splints work really well here. Ice packs, they talk about ice packs here. Ice packs are always a good idea. I should say always. Most of the time a good idea. When we're talking musculoskeletal injuries, it helps to reduce the pain and the swelling. So if you've got them, and then put them to use on these. They have a video about hip fractures for you, and then another one about immobilizing long bones. Both of those would be very beneficial to watch. And as we wrap up this chapter, remember that bones bleed. Splinting long bones involves immobilizing adjacent joints, and then immobilizing joints means immobilizing adjacent bones. Splinting protects the patient from any further injury, or hopefully will. And you got to be creative when you're splinting. This is one of the beauties of EMS. This is when we get to improvise. There are a lot of different ways to skin the cat in these cases. Injuries to bones and joints need to be splinted prior to moving the patient when possible, unless the patient is unstable or has a life threat. Then splint them with the long spine board, go back and improve it later. If the patient has multiple trauma or appears to have shock, do not waste time splinting. Get them on a long board, secure the limbs, transport, and then work on improving splints when you can. Remember that bones, joints, muscles, cartilage, tendons, and ligaments make up our musculoskeletal system. The bones provide the body with structure, store metabolic materials, produce red blood cells, and the joints are the places where the bones articulate to create movement. Fractures, dislocations, sprains, strains, or musculoskeletal injuries that are caused by direct force, indirect force, or twisting force. Injuries should be splinted prior to moving the patient when possible. Closed extremity injury is one in which the skin was not broken, and an open one obviously it was. Pelvic fractures and femoral shaft fractures often indicate the most severe internal injuries and have a high likelihood of impressive internal bleeding. EMTs have to learn specific techniques for immobilizing particular injuries, but at the same time be creative in the way that they do this, just simply applying the general rules of splinting. So questions to consider: have I fully addressed the life threats and maintained my priorities even though the presence of a grossly deformed injury? Does the patient have an injury that requires splinting? Does the patient have multiple fractures, multiple trauma, or shock? Do they have adequate CSM distal to the injury? Should I align an angulated extremity fracture? So our critical thinking question: patients who suffer fractures can be in extreme pain. Pain can cause anxiety and elevated pulse rates. How could you differentiate between a patient with a rapid pulse and anxiety from pain versus a patient with rapid pulse and anxiety from shock? Now remember, most patients who are shocky also have other signs such as nausea, vomiting, pale, cool, clammy skin, and they generally will have other injuries or other signs of injuries.